Good evening, everybody, and welcome back for those who have been here before, and welcome to the newcomers tonight. I'm very excited about the talk tonight for many reasons. During the organization, our speaker tonight, Dr. Basbaum, is a very busy man, and it proved very difficult to fit him in, but with shuffling things around, we managed. And this course is not complete without his talk, and I'm sure after tonight you will agree with me. Dr. Basbaum used to run MiniMed himself, so he knows all about it. So you can actually read all the details about his training in your little hand, the handout. But really, I think the excitement I feel tonight is that we are here having the opportunity to listen to the world's expert in pain. It's really, Dr. Basbaum also lectures to the students. The students adore his lectures, to keep it non-personal. And Dr. Basbaum is also very well respected by his peers. And if you, in the biography, jump to the last line, that's illustrated by the fact that he was elected into the Institute of Medicine. That's a really enormous sign of achievement. Also elected into the Academy of Arts and Sciences, and elected as a fellow of the Royal College in England. And really, anybody who can achieve just one of those three has made a significant impact in the field, and somehow Dr. Basbaum has done all three of those. So I feel really privileged to be listening to his talk tonight, and I really don't want to take up any more of your time. So welcome.
Whew. Thank you, Marieke. That was quite an introduction. It's fun to be here. It's fun to come back to MiniMed. As Marieke said, I did organize it years ago, and I thought it was time to turn it over to someone else. But it's fun to be back. We used to meet in Cole Hall, but they're renovating it, and we're optimistic it's going to look good. But this is a nice room, so welcome, everyone. I'm going to try to cover a lot tonight to teach. So I like to begin with this slide, which illustrates really what the big problem is. I am not going to talk about acute pain very much. It's not very important. This is what's important. This was a slide that I made from you can see 2001. This is about a gentleman who was dying of cancer. And as many of you know, unfortunately, that is associated with chronic pain, severe pain. But you do your best to treat it, and you use narcotics, and we'll talk about how narcotics work. Well, in this particular instance, the person was sent home, the individual was sent home, and for reasons that I cannot understand, the Chronicle reporter called me, we were talking about it, the individual was given Tylenol codeine. Now codeine is an opiate. It's a modification of morphine, but it's not very strong. And the individual died, as was expected, but in a lot of pain. The family sued. First time that ever happened, and they were awarded, in this case, $1.5 million. That was 2001, the most they could award. It'll be a lot worse. What is the lesson here? The lesson is very, very important, and it's really the bottom line, is that you can't see pain. You don't know what anybody's pain is, and unfortunately, if you think you know what it is, you tend to underestimate. It's hard enough to assess your own pain, let alone someone else's. And to illustrate how difficult the problem is, what I want everyone to, how many people have experienced pain? Okay. All right. How many people have experienced really intense pain that was really, now I know why you came. Okay. Now I want you to close your eyes, and I want you to re-experience that pain. Can you do it? And you wonder, it was so profound, it influenced your life, probably disrupted your life, and yet you can't even reproduce it. But you can close your eyes and think of your first love and get that warm, good feeling. Pain, you can't do it. It's so complex, and that's what I'm going to try to explain to you, how it's so complex, how we try to understand it, what some of the basic biology is, and more importantly, how do we treat it? Because there's lots of ways to do it. Now, pain's not all bad. All right? Here is a boy who has what's called congenital insensitivity to pain. This is somebody who has a mutation in a gene and never feels pain, never experiences pain. Now, as many of you know, acute pain is a signal. It's a warning signal. It says something is wrong. You may have broken a limb. You might bite your lips or whatever happened, and you stop and you learn. So acute pain is important, and to have a drug that would eliminate all acute and chronic pain would be bad. All right? Just for the record, there's a new gene that was identified, literally just came out 3 months ago, a Pakistani family, and it turned out the way they found them, these kids were firewalkers, and they just never responded. And they identified the gene, and the drug companies are hot on that gene because the hope is you can develop a drug to target it and control it. We'll see. But chronic pain is the problem. Acute pain is important. Some of the features that I'm going to talk about. First thing, pain is not a stimulus. Everyone says, that was a painful stimulus. Well, I use that term, and people use it. There's no such thing as painful stimuli. As you'll see, pain's in the brain. It's a perception. And what's special about pain, it's not just something that's an intense stimulus that might produce tissue injury. Pain has what we call sensory discriminative features. It localizes to a certain part of the body. It has certain intensity, of course. It might be thermal. It might be mechanical. It might be produced by a chemical. That's just one aspect of what produces pain. That's the stimulus. What's key in my mind is that it has an affective or emotional component to the experience. In other words, it motivates you. All right? If there is no emotional component to the experience, in my mind, it's not pain. It's just saying, yeah, that's intense. There actually are syndromes, people with brain lesions, who have what's called la belle indifférence, the beautiful indifference, where literally it's say, oh, yeah, that really hurts. Yeah, it's very intense. Sure, sure. And they go on reading. Just nothing. Just blank stare, nothing. In my mind, it's not pain. And then, of course, there's a cognitive component. And what I mean by that is the context in which you experience the injury or the stimulus will make a big difference. The football player who's playing and doesn't realize it because of the game. The woman who went through Lamaze. All right, I'm not suggesting that Lamaze eliminates pain. I wouldn't dare say that with an audience that's mostly made up of women. But it can reduce the pain. It can help. Same stimulus, two women with exactly the same stimulus, but two different pain experiences. All right? Somebody wants the baby, somebody doesn't want the baby. It will make a difference. So pain is much more than just the stimulus. And that's one of the reasons why it becomes very difficult to measure, because it's a subjective experience. You can't see it. If somebody is paralyzed, you can relate to that. You can pretend you're paralyzed. You can pretend you're blind. You can even pretend you have Parkinson's. You can have a tremor. You can walk slowly. But you can't, how do you pretend you have somebody's pain? You can't do it. You can't even reproduce your own pain. You can't see it, and so it becomes difficult to measure. But this is actually interesting and important. We use very simple tools, and this is now a requirement in the hospital, amazingly only recently. How many people remember when they were in the hospital and something started to hurt and you kept pressing the button until somebody would show up and they say, what's the matter? He said, well, the pain's back. And they might give you something and they go away, and then you keep pressing and they come back an hour later. Well, it doesn't work that way anymore. It's now a law that the individual, whether it's a nurse or a physician, on a regular basis must come in, take your blood pressure, respiration, and say, how much pain do you have? And they use what's called the visual analog scale, which goes from 0, no pain, to 100. And the important thing to understand about this, it actually works. It's very effective. But if you, sir, say my pain is 70, and you say 70, it doesn't mean you have the same pain. It's irrelevant. What it means is you started off, you came into the hospital with a 70, and we gave you some drugs, and now we ask you you say 40. Aha. You went from 70 to 10, probably gave you too much drugs, but it worked, all right? The difference, and it's very effective. If you have surgery and you have post-op pain and you're suddenly going from a 20 to a 70, I can actually scale it in the scaling. So it's very important. What do you do with kids? Well, then you use something called the Alcher scale. Children, you can look at their face and try to imagine how much pain they have, and it correlates, or their cries. Or you can ask the kids to point to the pictures. How much pain do you have? That's not good, all right? But you give this child some drug, a pain medication, and drop them down to here, you've done something useful, and you actually have some measure. So it's difficult, but it can be done. Now, clinical pain. This is the important thing. I said acute pain, it's a signal, we need to know about it, but it's really not clinically relevant. There are two types of clinical pain I'm going to teach you about. What we call nociceptive, or better to call it tissue injury pain with inflammation. This is the thing we're all used to. aches and pains, back pain. Arthritis is the most common, where joints, muscle are injured, strains, sprains. Cancer pain has tissue injury because a tumor invades tissue and then it generates pain. That's one type of pain almost always associated with inflammation. And as we'll see, you can treat it with drugs that treat inflammation, not surprisingly. Headache is a unique kind of problem. It would take me hours to talk about it, whether it's migraine or normal headache, but to some extent it falls into this category. Now, the interesting thing about this type of pain, and for that matter most clinical pains, patients come in and they say, I have a lot of pain. Say they're arthritic. Well, in fact, they don't have pain. What they have in almost all cases is a word that was invented not too long ago and it's stuck. It's called allodynia. All right, it's a word worth remembering. What it means is you have pain produced by normally non-painful stimuli, innocuous stimuli. What do I mean? Best example, sunburn. All right, sunburn, if you don't move, you're okay. Someone comes along and said, hi, and rubs your sunburned skin, that hurts. That's not normal. It shouldn't happen. Somebody slaps you. That's where you get more pain produced by a painful stimulus. Person with arthritis, as you'll see, it hurts when you move. That's not normal. That's the problem that you need to treat. If they don't move, actually, it doesn't hurt. This illustrates the problem in a very nice way, what the clinical problem of pain really is. And it's totally arbitrarily generated. What I've plotted here in a slide I borrowed from Fernando Cervero in Montreal, just arbitrarily on the y-axis, I'm plotting the amount of pain as a function of the intensity of the stimulus. So I might be pinching very intensely and keep increasing the pinch if I had a little machine. When the stimulus enters what we call the noxious range, which is really a point at which if I continued to hold it there, it would produce injury. It would actually produce frank injury. All right, it could be a burn. I could take something hot, keep it there, and after a while you're actually going to burn tissue. That's a noxious stimulus. It's painful. If I increase the intensity, you get more pain. Totally normal acute pain. Totally normal pain. If I give this individual morphine, it'll take much more stimulus to get the same amount of pain. That's not very interesting. It's normal pain. What we need to explain and what the clinical problem is, and I will explain how it happens, how it's generated, and how to treat it, is in the setting of what's called insult or injury, effectively the dose-response curve for pain shifts such that now we get into a phase where an innocuous or normally not painful stimulus, like just moving your fingers, is now painful. This we call allodynia. This is the clinical problem of pain. Believe it or not, that's the major problem. People can't get around because normally non-painful things start to hurt. Warm temperatures hurt. Cool temperatures hurt. Moving hurts. Wearing clothes hurts. It's very difficult to get on with your life when you have constant pain produced by the normal stimuli in which we live. An example, a rather intense emotive example. This is somebody with severe arthritis. It could be rheumatoid arthritis, could be psoriatic arthritis. You look at it and you say, well, there's tissue injury, the joints are all distorted. Yes, they are. But if you ask the individual, when they don't move, it doesn't hurt. But as soon as they try to move, try to tie their shoelaces, it starts to hurt. That's the problem we need to treat. That's a type of chronic pain that is serious. Now, the other major class of chronic pain, which is treated by very different drugs, we call neuropathic or nerve injury pain. This is pain that results from damage to nerves, whether there's nerves in the arms or the legs, or in fact, it could be nerves in the spinal cord or the brain. Post-stroke, patients have pain. Spinal cord injury, where you see somebody who is paralyzed and they can't walk. The fact is 70% of people who have complete spinal cord injury who are in a wheelchair, they have severe pain. That's their big problem, in fact. They'll say, look, doc, if you can get rid of my pain, I don't care if I never walk again. You've got to do something about my pain. That's a neuropathic pain. Multiple sclerosis, which involves nerve damage, is associated with pain. And there's many examples You might have heard, I'll show you a picture of post-herpetic neuralgia. Everyone knows what shingles is? All right? Shingles is the zoster virus. It gets in, and you might have an outbreak of vesicles on your skin, in the chest, or maybe in the face. In most people, in 80% of people, it'll clear up. It's unpleasant, it's painful, but it clears up. But in about 20% of people, it doesn't, and you get left with a nerve damage, because the virus destroys some nerves, induced horrible pain, post-herpetic, after the herpes lesion, neuralgia, meaning pain. Cancer pain, tumors invade tissue, they'll invade normal tissue, and you get inflammatory pain, and then they'll suddenly invade a nerve, they might go into the spinal cord, and you can have horrible neuropathic pain. Much more difficult to treat than the other type of pain. We'll talk, diabetic neuropathy may be the worst, maybe 30 million people. 40 million people have diabetes. Eventually you can end up with nerve damage, and you could end up with severe neuropathic pain. The other horrible example, unfortunately, is chemotherapy. Chemotherapy is where you're trying to kill tumor cells. Unfortunately, the same drugs that do that will destroy nerves and can produce neuropathies, neuropathic pain. So that the ways to generate chronic pain are abundant. There's no reason to have chronic pain. We need to do everything we can to understand it and get rid of it. Neuropathic pain is also associated with the fact that innocuous stimuli produce pain, and in the worst case, there's often ongoing burning pain. If a patient comes in and says, "Doc, my arm is burning all the time," you immediately think there's some kind of nerve damage. It's almost a hallmark. Examples. This is a woman with post-herpetic neuralgia. It's in what we call the trigeminal nerve division. Literally, if I took a hair and just lightly touched the head, she would have paroxysms of pain. Air blowing in the room from an air conditioner could set it off. If it's on your chest, it's hard to wear clothes. So this is a severe type of pain, and unfortunately, it's all too common. This has many names. Reflex sympathetic dystrophy, you may have heard that term. Complex regional pain syndromes, the names keep changing. Here's an individual who had the slightest little nerve damage, the slightest problem. Wasn't even aware necessarily that there was some trauma. And look what happened to the arm. It started to swell, excess hair growth, the nails get glassy, and this arm is in excruciating burning pain, and light touch can send this person into paroxysms of pain with the slightest, mildest nerve injury. Very difficult to treat. Phantom limb pain is one of the more provocative ones. Everybody who loses a limb has a phantom. In the old days, they thought these people were nuts. They're not. The reason why you have a phantom, let's say I lost my arm, is that there's a representation of the arm still in your brain. As long as it's there, you're going to feel your hand. And people mostly, they can move it, they can control the phantom, they can move their fingers. It's pretty wild. In about 20% of people, the phantom is locked in a position. The nails, they'll say, are digging into my hand. Do something. Stop my pain. Phantom limb pain, you can get phantom teeth pain. Any part of the body, you can end up with phantom pain. Very difficult to treat. Another neuropathic pain. Fortunately, there are ways to treat it. They don't always work, but you never give up. And I'm going to try to cover as many of these as possible. Aspirin and what we call NSAIDs, and I'll explain that. Opiates. Morphine. How many people think morphine's a lousy drug? Oh, you love it. We'll get into that part too. All right, morphine. We'll talk about stimulation on the skin or stimulation in the brain. We'll talk about placebos. We'll talk about acupuncture, and we'll talk about hypnosis, all of which have a place in the treatment of pain. And I'll try to tell you what works, what doesn't work, how I think it works, and you can see if we can hopefully make everyone's lives a little better. So let's begin at the beginning. In the very old days, and people who give pain lectures like to go back to Descartes. Descartes, I think therefore I am, same guy, he wrote a lot about pain. And he drew this diagram in the 17th century. And what he said, well, I show this, I bring it up to modern times. Okay. So the fire, what Descartes said in French, of course, the fire burns foot B, and they didn't know about nerves, they didn't know about synapses, they didn't know about any of that. But he said somehow the information travels up the spinal cord, and it gets to the brain, and you get pain. It's very simple. Now, the sad part is I teach medical students, and you look up in any textbook, and the modern neuroanatomy textbooks don't look all that different. All right, got to add the fire. Okay. Basically, doesn't this look like Descartes? In this case, we've thrown in nerves and we've thrown in synapses or connections between nerves, and we have nerve fibers in the arm, say, that get burnt. The skin gets burnt, the information goes into the spinal cord, you have a connection, the information goes up to the brain, and somehow you get pain. The problem is this is all about acute pain. This is how you get acute pain. You burn yourself, you stick a needle in, somebody pinches you, and this works. Of course, as I told you, it's not important. If indeed it were important, how would we treat this problem? Guaranteed to work 100% of the time. How? Well, take his foot away from the fire. That's one way to do it. But let's assume that his foot is paralyzed and he can't move it away. I want to treat this person who has chronic pain, and this is the mechanism. It's just a pathway that goes through. How do you treat it? Cut it. Cut it. Right? Do you agree? The brain's not going to get any information if I cut it. The analogy I like to draw, which doesn't work with the students because I know what the hell I'm talking about, is a telephone. Right? Here's a telephone, and it has a wire. And if you cut the wire, the telephone doesn't work. Now, I tell the medical students, and they look at you with this blank face. They take out their cell phone, and they don't know what you're talking about because there's no wires. But anyway, I think we understand. The wire is essential for communication. If indeed cutting doesn't work, what it means is there is no pain pathway. All right? Nevertheless, neurosurgeons continue to cut. They try because patients who have severe pain and aren't responding to drugs will seek out somebody who will offer something new. And this is an interesting diagram of the pathway that takes information from, in this case, the foot up to the brain, and it illustrates some of the procedures in red that continue to be done. Whether cutting a nerve in the leg to block pain, in the spinal cord, if it doesn't work low, do it a little higher. Take out areas of the brain, literally chunks of cortex, or even do a variation on this, a frontal lobotomy. We all remember the 1950s frontal lobotomies. Well, I told you that pain has an emotional component to it. Well, somebody reasoned that I can eliminate the emotional the ability of this patient to experience emotions. It works. Sort of destroy their personality at the same time, but this is done, and in some places it continues to be done. If indeed there were a pain pathway, you wouldn't need to cut it all. You just got to cut down here, it would work. It doesn't. Conclusion, there's no pain pathway. So what we need to understand is, where does everything fall apart? Where does the idea of a specific pain pathway actually break down? And the answer is it breaks down real early, right out in your arm, in your leg, and I'll try to explain what's going on. So let's talk a little bit about the anatomy and biology of pain. So what we're looking at here, I take your spinal cord, which is a big long tube, and I'm going to cut it like this and look at it, and this is what it looks like. And here's a foot, and here's a nerve that's in your foot. The nerve has a cell body, but it has a branch that goes out to the foot, and then it goes into the spinal cord where it makes a connection with a bunch of other nerves, and we don't have to worry about the details. That information goes out and then goes up to the brain. Seems so simple. This is real anatomy. It's there. But if we look at a peripheral nerve, all right, if we look at a peripheral nerve, we find that they're all different size nerve fibers. They're not all the same. And if we look at them, this is one example of what a peripheral nerve looks like, all right? What you have are large fibers, and you got little ones. The large ones have what we call myelin. They conduct very quickly. Those are the ones, the largest ones respond to light touch when you bend your fingers, to hair bending. They respond to innocuous, non-painful stimuli. The small fibers, these guys and these guys, respond to painful type stimuli. Seems so simple, all right? But the small fibers only respond to painful stimuli, but in the setting of tissue injury, they can respond to innocuous stimulation. So when there's injury, they change their properties. And how they change their properties is very clear, and I'll show you how it happens. And they change it such that now non-painful stimulus can hurt. So let's look at an example. It's what we call sensitization. It's happening out in the periphery, so it's peripheral sensitization. Here's our fiber. And now we've just rammed our foot against the wall, or somebody drove a car over your foot, and they've produced a lot of damage. They produced a lot of tissue injury in the region of that nerve fiber. What happens? You change the chemistry of your foot. You destroy cells, membranes get broken down, enzymes get synthesized. It's a mess. Everyone sees, you see swelling, you see redness, inflammation, right? And there's a lot of chemistry going on, and one of the key things that happens, and don't worry about this name, the med students can't even remember it either, you get the synthesis of a molecule called arachidonic acid. There's no exam, don't worry about it. But what's really important is arachidonic acid gets attacked by an enzyme called cyclooxygenase, or, as many of you know it, the Cox enzyme, the famous Cox enzyme. And when that enzyme acts on this, it produces a molecule called prostaglandins, which then act right on the nerve fiber, and then that lowers its threshold, and now you have allodynia. So that nerve fiber before would only respond to pinch, and now light touch will make that nerve fire. Light touch will now produce pain. Before it only responded to 45-degree stimulation. Now it responds to warm bath temperature. All right? Its threshold dropped, you have pain. How do you treat this? How would you treat this? Well, let's block the Cox enzyme. And you guys, how many people have ever had aspirin? That's all? Well, that's what you do. You use Cox inhibitors, and these are non-steroidal anti-inflammatory drugs, the NSAIDs, and these Cox inhibitors are aspirin, ibuprofen, naproxen. They all do the same thing. They're all variations on the same drug. And they work. They block the Cox enzyme. And then, of course, there's the real famous COX-2 inhibitors. And if you've been reading the newspapers, you know that COX-2 inhibitors, Vioxx and Celebrex, which I happen to think are dynamite drugs for pain. They work beautifully. You take one pill in the morning, one a day. Isn't that nice? Unfortunately, it has cardiovascular side effects. And so they're off the market. And your Merck shares are worth a lot less because of that. All right? But it's a very good drug, and we know exactly how it works. And the reason why the COX-2 inhibitors were developed, it was thought that they'd have a better side effect profile. Because everyone knows that one of the bad side effects of aspirin is you can get an ulcer. It can burn a hole in your stomach. It's a side effect. Now, let's take a little bit of a sort of side important thing. Side effects do not mean the drug is a lousy drug. It's inherent in any drug you take. The nervous system, the body, is very conservative. It uses the same molecules over and over again. So when you pop the pill, the drug's going to start going all over the place, and it's going to kill Cox enzymes everywhere it finds. And I gave it this mini-med. I love this. A gentleman put his hands up several years ago. True story. And he said, "Doctor, this sounds like a stupid question." I said, "There's no stupid question." He said, "Well, you know, you told me about I have arthritis, and I take aspirin, and it goes and it blocks the Cox enzyme." And he said, "How does the aspirin know where to go?" It was brilliant. Because he was understanding the problem, the side effects. The aspirin has no idea where to go, right? You put it in your mouth, and it's going to get in your bloodstream. It's going to go everywhere. And if there's a Cox enzyme that you need in your stomach, it's gone, all right? So the game, if you will, the goal with the development of any drug is to have lots of effect and little side effect. And to the extent that they get too close together, the drug becomes a real problem. But don't assume right away that because there are side effects that therefore it's a lousy drug. It's an important concept because something like morphine has lots of side effects. The trick is to build up its effects and reduce the side effects. Now, I talked about the small fibers, and I told you those are the ones that respond to painful stimulation. Well, what about the large fibers? Do they do anything? Do the large fibers do anything? Well, they do not respond to painful stimuli at all. I can assure you, they don't. We know that. And the question is, do they do anything? Well, let's see. It turns out that when they're active, they can actually reduce pain. Let's do an experiment, all right? Everybody. We walk into the kitchen, and on the stove is a hot pot. boiling water in it, and you're concentrating on something else. You walk up to it. I want everybody to do this. It's San Francisco. We can use our imagination. Pick up the hot pot. I want you to act it out. What do you do? All right, you dropped it, and then what did you do? You shook your hand. Think about it. That's pretty weird. I mean, you just massively stimulated your hand, and you burnt it, and you stimulated some more. You say, that sounds pretty dumb, but why did I do? Well, let me tell you, when you shake your hand, you're activating large fibers. You're trying to bring in these fibers that have the capacity to block pain. That works, or you can rub it, or you can put a vibrator on it, which works, or a transcutaneous electrical nerve stimulator on it. You're always doing the same thing. These are fancy ways of blocking pain. Now, unfortunately, some people have injury to their large fibers, and then the pain gets worse. Let me illustrate this. Cold water? Well, what cold water does, it doesn't really block the pain. It lowers the temperature so that you reduce the likelihood of producing a burn. All right? The longer the heat stays on, the more you're going to burn tissue. You reduce the temperature. And in fact, when you walk across hot coals, I tried that once. It hurts. But I did it. You walk across hot coals, and I did it with some guys. I do some stupid things sometimes. But it's surrounded by cool moss. And what you're really doing is you're lowering the temperature of your feet. And then you walk across and you pray that in fact the temperature doesn't reach the point at which you end up burning your feet before you get to the other side. So what you're doing is you're lowering the temperature, you're not actually blocking pain. It's an interesting question. So you have small fibers, they come in and cause pain, if you will, and you have the large fibers that come in and they can block the pain. All right? So you can shake your hand, you can put a vibrator on, it works. All right? Little vibrator around the area that hurts will actually help the pain. You can put a TENS unit on. That's like a $300 vibrator. It's basically the same thing. It's expensive. Transcutaneous electrical nerve stimulation. Or there's even a form of acupuncture that I think works that way. There's some forms of acupuncture where you put a needle here to get pain here, to block pain here. In many cases, you actually use the acupuncture needles in the area that hurts. I think that's no different from vibration or shaking your hand, but it works and it makes perfectly good sense. What happens if you actually lose the large fibers? And there are clinical conditions where that happens. Well, I can model that. All right? Now, this is someone who worked in my lab, Dana. She's now on the faculty here. She agreed to be to get filmed doing this because they don't allow me to do it anymore. And so I used to get someone from the audience to be a subject in this experiment. So let's assume that Dana has small fibers in her arm. And she has large fibers in her arm. And the question, what happens is if I remove the large fibers. And I can do that by putting this blood pressure cuff on her arm and blowing it up above systolic pressure. So I block all the blood supply to the arm. And the large fibers have a very high metabolic demand relative to the small fibers, and they're gone. Large fibers, by the way, also make your muscles go, so the arm will be paralyzed. So you can see why maybe they don't allow me to do it anymore. But it illustrates something, and a friend of mine said I gotta get a new film of this because I'm 30 years younger when I did this, but that's okay, it looks good to see. So let's see what happens, and hopefully this will work. It takes about 5 seconds to start. So, I put this blood pressure cuff on, and then I'm going to do a simple neurologic exam. Let's see what happens. This area with a piece of gauze. This is the normal hand. Okay, so there's no response to like tactile stimulation. Now let's try joint position stance, conscious joint position stance, which we know is also large. It would activate the small fibers.
Okay. All right, then tell me what you feel. Where is it? Which finger? That's pretty good. So that almost certainly suggests that there is an A delta function doing fine. The A delta will give you some localized sensation. The A delta will not functioning at all, there will be no response. All right? Tell me again, what do you feel this time? Nothing?
Well, yeah, I think I feel like the burning pain on it's sort of
All the fingers, okay. So there really is some poor localization, but the sensation of pinch is burning. All right? Okay, all right. Okay. Tell me what you feel. Tell me whether you feel sharp or dull. Feel anything?
no, just a little bit of a background burning. I don't know what it was.
Remember the word burning.
I don't know burning.
Where?
I think I'm going to tell them
Okay, so pinpricks also produce burning. Okay, let's try just one more thing. Okay, this is the stimulus. All right, everyone can see what it is. Tell me what you feel.
It's ice.
Burning pain. Okay, this is a piece of ice. All right, Dana, okay, hold this in your right hand. What does it feel like? Because we're all. Okay, try putting this in your hand. Tell me what you feel. Yeah. Put it on the back here. Okay. All right, maybe we won't do that. Okay. The point is that you need to put it on first. You want to try it again? Okay, hold it for sure. What do you feel in your left hand?
Well, now it's burning.
So it takes a while.
Burning pain produced by ice, pinprick, pinch. Remember I said if a patient comes in and says something's burning, you think nerve injury. That basically models remarkably well some of the clinical neuropathic pain syndromes. If you put the cuff on somebody with a right arm neuropathic pain, they'll say, that's my pain. Now you know what it is. There's no other way to appreciate it. All right? It's pretty dramatic, and it illustrates that the pain perception is far more complex than just the nature of the stimulus. So what about chronic pain? A couple of important things. It is not merely prolonged acute pain. We don't mean that it just lasts a long time. It's the same as acute pain. As you can see, that was totally different. Acute pain is the pinprick and the ice. Chronic pain completely changed. The quality changed in the setting of injury. It's not merely a symptom of some disease. This is a take-home message. Yes, pain is associated with cancer, and pain is associated with MS and spinal cord injury, but pain, chronic pain, is a disease itself. It's a disease of the nervous system. The individual who has chronic pain has a nervous system that is different from the individual that doesn't. It's an altered nervous system. It's a neurological problem, and understanding it is something that really is critical in order to identify new ways to treat it. Now, interestingly, the public doesn't appreciate that, and when someone unfortunately dies of whatever the disease, and this isn't a sales pitch, they always say, give money to the such and such foundation, the disease that killed the individual. They will never say, even though the person may have died in pain, they'll never say, give it to the pain foundation, and the reason why they don't is there is none. And the reason why there is none is that everyone thinks of it as a symptom. But in my mind, it is really a disease. And the fact is, we now understand the nature of the disease, and it is really a problem of what we call central sensitization. I want to teach you a little bit about that. Another word for it, if you will, are pain memories. Maladaptive memories that the nervous system creates in the setting of injury, and when those memories persist, you end up with trouble, big trouble. Newsweek, by the way, you may have seen, had an article this week on pain, and they talked a little bit about this notion. They didn't use these words, but that's basically what they were talking about. So what I'm saying is that central sensitization is a process whereby when there's tissue injury, you don't just get information that goes to the brain and end of story. You get changes in the central nervous system, in the spinal cord, in the brain, that enhance the flow of information and make things worse. And those memories last. They can last a long time. If you have nerve injury, it can be worse, because now you're disconnected, you have nerve injury, and the area of the injured nerves start to fire like crazy and send information to the brain, and that in turn produces changes all along the path, and again, central sensitization, long-term changes, maladaptive memories, more pain. Another way to look at it is, if you have a little stimulus, under normal conditions, it produces a little pain. That's acute pain. You might even have an acute nerve injury and may get a little bit of pain. And it goes away. It should go away. But if this process persists so that you get central sensitization and these memories, biochemical changes occurring, an altered nervous system, you now have much more pain. That's the problem that we need to treat. This is the nature of chronic pain. All right? Now, I've focused all about what's happening here, and I've talked about what's happening in the spinal cord a little bit, but I said there's no pain in the spinal cord, right? There's no pain in the foot. Where's pain? That's right. No brain, no pain. This is where pain is. All right? This is where pain is, and we're only now getting a handle on the nature of how the brain generates a pain experience. Because the brain is monitoring all this information. Sometimes it can't do anything about it. I find it fascinating that Dana could take that piece of ice in her right hand and say it's freezing cold and put it here, and the brain knows it's ice, and yet it's burning. The brain could not overcome what was clearly an illusion. Very powerful. It's what it was, is an illusion. It's not burning, but it's interpreted as such because of the damage, quote, that I had inflicted. So, where in the brain is pain? That's what I want to talk about a little bit. Well, it was asked by Bertrand Russell a long time ago. He was visiting his dentist. Bertrand Russell, British philosopher, kind of a character. And he was asked by his dentist, where does it hurt? Your dentists always ask you, right? And what he said, in my mind, of course. So he understood my lecture. It doesn't hurt in your molar or your incisor or here. It hurts here in your mind, and your mind is your brain. And what I'm going to try to explain is how that comes about. We used to know nothing about it, but remember I told you there's different features of the pain experience. Sensory discriminative, where is it? What kind of stimulus? How intense is it? Well, and then there's the emotional feature. How unpleasant is it? What will I do about it? Why does it motivate me so much? Very different features. It turns out the brain processes things differently. The analogy I like to draw is seen in this. And I show this to the medical students. You recognize this as a Mondrian, Piet Mondrian, a Belgian artist who painted these interesting paintings. This one I think is called Yellow Number 23. Now, your retina, you walk by and your retina sees this. And the information goes to the part of the brain, the visual cortex, and you get a perception that looks like this. Now, two different people. One walks by, just keeps going. You know, where are the Picassos? Where's the Rembrandts? I don't get this. You know, another person walks by and just stop dead in their tracks. Tears, you know, start flowing down. They understand what drove Piet Mondrian to paint this. And they're moved. There's an emotional experience attached to this physical stimulus. And they might take out their wallet and write a check, you know, for $20 million. The first guy wasn't paying anything for that painting, right? What's the difference? The difference is affect, emotions. And beauty really is something that's not inherent in the stimulus, just like there's nothing painful in the stimulus. And I think if you think of it that way, and the areas of the brain that light up when you get an emotional charge of this are not all that different in some respects from what happens when you have a pain experience. It turns out, we now know with imaging, which we never had a handle on anything in the cortex before, there's no one pain area in the brain that you could cut out. Forget it, it's not going to happen. Doesn't exist. There's no beauty area in the brain that you could cut out. What there are areas that light up, and the areas aren't important other than to say that there are areas that correlate with the intensity and with the location. But there are very different areas that light up or are active in association with the emotional power of the pain. And it's what we call part of the limbic or emotional cortex in this area here, which I'll come back to, for the aficionados, anterior cingulate gyrus. It lights up like a Christmas tree, and the more unpleasant the experience, the more it lights up. This is the part you really got to get rid of in order to treat pain. The stimulus sensory thing, that's fine. This is what is the problem. So, the bane of pain is plainly in the brain, is what I like to say. All right? But where? And to what extent? Now we're going to talk about things that influence the perception of pain. Well, it depends. It depends on who is stimulated. Here's 2 imaging studies. All right, one set of images in one individual and another individual. This is a different part of the brain in one individual, another. Let's just look over here. It looks different. It was the same stimulus. Got quite a bit of activity here. You got a lot more activity here. What's the difference between these 2 individuals? It's a woman, that's a man. Women, given stimulus, actually lights up more of their brain. Women, by the way, by and large, everybody has pretty much the same pain threshold. It's one of the misconceptions of the world. 45 degrees pretty much will hurt everybody. Women, a little bit less. Women actually have a slightly lower pain threshold. And so the guys say, ha, I knew it. Wrong. They have a lower pain threshold, but where they differ, and it's so interesting, is women have a much higher pain tolerance. There's a distinction. So when someone says, I can tough it out, they're not saying that I have a high threshold. No, you don't have a high threshold. You have the same threshold pretty much. But how much will you tolerate before you say, uncle, I quit? Women have a much higher tolerance, which I think, a guy probably could never deliver a baby, given the difference. And the differences are quite substantial. So there are gender differences that are clear. And there's probably genetic basis for some of those differences. It depends on the state of the individual when they received the injury stimulus. I love this one, all right? Is that a noxious, painful stimulus? Well, to somebody it might be. To this guy, he's cool. No pain. Saint Sebastian, is this a noxious stimulus? You bet it is. Is that somebody in pain? No, he's somewhere else. The stimulus does not determine whether or not it's painful. It's much more than that. It depends on, this is an intro, how much attention is paid to the stimulus. Here's somebody climbing, I don't understand why anybody ever does this. They just built one over at Mission Bay. They're climbing a rock wall, and they're ruining the hell out of their fingers. Anyway, is it painful? To me, it would be excruciatingly painful. Is this person concentrating on the pain? Almost certainly not. Here's an imaging study that illustrates how important attention is. Your dentists use it all the time. You sit there and they turn the music on, like that's going to help, right? Lamaze. What is Lamaze? Other than attention, distraction. I mean, we went through it. You pay $60 and you bring a pillow and they teach you how to breathe. You've been breathing all your life. They teach you how to focus on the ceiling and all that type of stuff. It's teaching you about the birth experience, about the biology, and it's teaching you how to focus attention elsewhere. Here's an imaging study that is quite dramatic. All right, here's the activity in the brain. The person has earphones on, and then you have a painful stimulus on the hand and you light it up. Now through the earphones you put music on. You have music before, but you ask them to attend to the heat stimulus on the hand. Now you put the music on and you have the heat stimulus. You say, I want you to attend to the music. The activity gets reduced. The information in the brain is altered just by the fact that the subject is paying attention to something else. One of the most powerful things a physician can do with an individual is to get them to concentrate on something else. Get them to get out of their home. The worst thing for a patient with chronic pain is to sit at home and just think about their pain all the time. Get a friend, get out of the house, go do something, go to a movie. It makes an enormous difference. It depends on how much pain you expect to experience. If somebody tells you, boy, this is really going to hurt, it hurts. It hurts more. And you say, well, you know, that can't be. It doesn't make sense. It's the same stimulus. Well, here's an imaging study. Here's the amount of activity produced when you tell the subject, this is going to hurt. And you get some activity. Now use a warm stimulus. This was hot. This is warm. And you get next to nothing, little activity, but a blip here. Now you tell them, this is going to hurt, but you give them the warm stimulus. And you get more activity. The brain is prepared for these things. And the amount of activity is not where pain is, but it's contributing to the gestalt of whether or not and the magnitude of the experience. All of these things contribute. It's not just the intensity of the injury at all. And the problem, of course, is the physician who thinks they know how much pain you have. What are they paying attention to? Or your friends who don't believe you when you say it hurts? They're saying, gee, you know, you got a little boo-boo cut on your foot. Come on, stop complaining. They don't know what's going on in your brain. And it's a big problem because to the extent that you think you know how much pain they have, you'll end up being, your friends or the physician will under-medicate you. Happens all the time. Incredibly, this is unbelievable, new study. Imaging of the brain of an empathetic spouse. So you've got the husband sitting in the scanner and he's being, the wife thinks that the husband is experiencing some excruciating, painful stimulus. Imaging the brain, and you end up that the wife starts to manifest changes in her brain that are equivalent to those that the painful stimulus would produce in the husband. That's pretty freaky. The most bizarre and perhaps unfortunate thing is it doesn't work the other way. You put... Yeah. Excuse me? It's Herta Floor from Germany who published it. I don't remember the journal, but I can get it for you. All right? The question was he wanted the author of the study that did this. Okay? It's a hell of a study, let me tell you. They don't empathize is the answer. Is that a big surprise? No. I don't. What can we conclude? You cannot predict. And I'm talking to a physician here and to the friends of someone with a pain problem. You must never assume you know the magnitude of quality of somebody else's pain. You listen, you believe. If you don't believe them, just disappear. If a physician thinks the person is a crock, send him to someone else because you're going to be doing them a disservice. It happens all the time. People inevitably underestimate and people get under-medicated. I'll go on. Now I'm going to switch gears, and we've talked about some of the pain control procedures, and now I'm going to take you through some of the others. It won't take all that long, because we talked about the major one. But what I want to talk about is opiates in particular. Now, we talked about things that work locally. In other words, if you burn your hand, you know, you don't kick yourself in the foot, right? You do things on your hand. You rub your hand, you shake it. I talked about sort of localized acupuncture. It actually has a name, dermatomal acupuncture. And we believe it's an interaction of large and small fibers. Very straightforward. But there's something that is much more broad. It turns out the brain has internal pain control mechanisms, what we call endogenous pain control mechanisms. And there's a variety of ways to tap into them. Some of them you've heard of, like the endorphins. I'm going to talk about that. But I want to introduce it by telling you about a procedure that is still used, although albeit considerably less than when it was first discovered, called deep brain stimulation for pain. So this is only used for patients who really nothing is working and they can't take, morphine might work, but the side effects are intolerable. And so this is what you're left with and what is done, and it's based on work in animals. Where here's an X-ray of an individual who had an electrode implanted in their brain. Now, the procedure is done while the subject is awake, the patient is awake, because you anesthetize the scalp and the dura, the covering of the brain. You open it up. The brain itself is pain-free. You can do anything you want. You wouldn't feel a thing. So the patient's awake. You drop this electrode down and target an area. Well, I'll show you where it is. You bring the leads all the way down under the skin to the chest. And then you have a little battery pack, and you just zap yourself, sometimes continuously, depending on the target, sometimes 4 or 5 times a day. And in the best of cases, pain just disappears, melts away. I have some movies of patients. It's quite dramatic. Does it always work? No. Can you predict when? No. Is it for everybody? Absolutely not. But when it works, it's dramatic. But what it tells us is that there is a system in the brain. It's not a placebo in this case. We're pretty certain of that. And we know how it works. I'm going to just show you a diagram. We talked about information coming into the brain and going up to and causing pain. Well, it turns out that there are control systems in the brain that act down to shut off the information that goes back to the brain. And that's what's happening. So you target an area in, names aren't important, in the midbrain of the brain. You stick an electrode and you zap it. And when you do that, you activate a control system. There's a big minus sign here that literally shuts off the spinal cord. But selectively for pain inputs. You can still walk, you can feel touch, but you don't feel pain. It's not selective, it blocks it everywhere. Most interestingly, it doesn't work very well for acute pain. You can still feel pinprick, but you can't, if you have chronic back pain or something like that, it can actually eliminate it. Now, what's exciting about this and dramatic and why we learned how it works is that it turns out if you inject a drug called naloxone, which some of you may know as Narcan, the trade name, the pain relief disappears. You stimulate in the brain, you give this drug, and the pain comes back. Does anybody know what this drug is? This drug is an opiate or morphine antagonist. Somebody comes into the ER on Saturday night in a coma, you immediately give them Narcan. It should be called Narcant. I don't know where they came up with the name. It's Anyway, the point is, what does it do? The likelihood or the fear is this was a heroin overdose. Heroin is an opiate. The patient is in respiratory depression. You give them naloxone, they're up in a second because it just kicks the heroin off the opiate target, and the patient literally just wakes up instantly. Well, it turns out that same naloxone will block brain stimulation, produce pain relief. So how does that work? Well, I got to take a little segue, and let's talk about endorphins. So we have opioid receptors, or opiate receptors. These are the molecules, the key, the locks, if you will, that are hit by morphine. But they're also hit, they're not there because people were shooting up morphine. That's not how it works, all right? What happens is there are endogenous compounds that bind this, and of course, these are the famous endorphins. Everybody's heard of endorphins? I'm going to dispel, unfortunately, I'm going to disappoint you when I tell you what I think of endorphins in a minute. But endorphins act on opioid receptors. And that's what happens. When they bind, they trigger a whole variety of reactions in the brain. These are endogenous. They're made by the brain. And naloxone will block it. That's simple. Conclusion. The conclusion is straightforward then, that when you stick an electrode in the brain and stimulate, you must be releasing endorphins and then turning on this control system. So you're tapping into an endorphin system. You're literally tapping into it, releasing the pain-relieving substances, and poof, you get pain relief, and it's blocked by naloxone. Is that clear? Pretty straightforward. You have a pain-relieving system in your brain. Naloxone's the key. Now, how does morphine work then? Well, then it gets simple, because if we have endorphins in the brain and they bind this, I can inject something from the outside, like morphine or OxyContin or codeine or Percocet. All those are opiates. They bind the receptor, they're exogenous, and you end up with pain relief. It's that simple. So what we believe happens, here's the brain, here's the spinal cord. Somebody comes in, and now I'm going to give them a shot of morphine. I want to block pain. How does it work? The morphine is given systemically, which means it's going to distribute throughout the body. Could be in a muscle, could be subcutaneous, could be an oral pill, could be intravenous. Doesn't matter. It's going to go everywhere. It's going to bind the same place where the brain stimulation was. It's going to shut off the spinal cord, and you're going to get profound pain relief. Great drug. Severe pain, morphine is the drug of choice. Period. There's nothing better. I wish I could say there was. There isn't. Now, how many people think morphine is a good drug after I just said that? How many people think morphine is a terrible drug? Be honest. How many people are afraid to take morphine? How many people think the guy who's just been put in jail, the physician you may have seen on 60 Minutes, 25 years in prison for prescribing lots of opiates to his patients? Problem. Why is that? Well, because morphine has side effects, lots of them. But the side effects are perfectly understandable. They're because the opiate receptor is not just where the pain control system is, it's all over the damn place. There's an area that controls breathing. It has opiate receptors. That's the reason why an overdose will kill you. You stop breathing. There's an area in the limbic system. Remember the emotional part of the brain? Well, it has opiate receptors. And that's why junkies shoot up heroin. They're not trying to get pain relief. They're trying to get a high. All right? And it makes perfectly good sense. When you feel good, maybe that's what's going on. That's a side effect when you're trying to block pain. And perhaps the worst one in the case of the clinic is constipation. How many people in the audience have had diarrhea? See, you're honest. It's very interesting. Medical students, nobody has diarrhea. It's quite amazing. Maybe only at UCSF, but if I ask that question, 2 hands go up. Anyway, suffice it to say, I'm sure they all did. How do you treat diarrhea? What do you do? Paregoric. Well, you take the good stuff. Imodium? Kaopectate, remember that? You know what that is? It's an opiate. You're taking a narcotic, but a brilliant opiate. It is designed by the drug company to be in a form where it cannot get into the central nervous system. It cannot cross the blood-brain barrier. It's stuck in the periphery, but that's where the gut is. You want to shut off the gut, and you don't want it to get into the brain. It works beautifully. All right? It's just understanding biology. Yes, sir? Well, Pepto-Bismol works for constipation? Oh. Oh, for diarrhea. No, fair enough. You're right. You're absolutely right. I agree. Doesn't work as well as anyway, we'll talk about that later. Doesn't work for me, but I, of course, never had diarrhea either. The problem is we have all these side effects, and what are we going to do? We need to find a way to get the pain relief without the side effects. That's the goal we talked about with aspirin. It's the goal. And it turns out there is a way to do it. It's not a way you can do it with everybody, but it's very common now. It turns out that the spinal cord has lots of opiate receptors, and it's possible to inject the drug right at the level of the cord. And this is done all the time now. It was discovered by Tony Yoch in rats years ago, and within no time was adapted to humans. It was initially used, and it is used all the time for women post-C-section. I'll show you an example. It's now put in pumps for people with chronic pain. And the beauty of it is it blocks pain because it blocks the output, but it doesn't produce the side effects because it can't get to the brain. The doses are too low. You don't get constipation because it's nowhere near the gut. It's terrific. What you do is you pour the morphine epidurally around the dura. It gets into the cord, or you can use fentanyl or whatever. It seeps into the cord, and it literally shuts off the spinal cord, and it works. It's remarkable, very effective. This is a woman. I took her picture. She had a C-section 2 hours before. 2 hours before. She had epidural morphine put in. It'll last for hours because it sort of sits there. No paralysis. She can feel things, but no pain. She can take care of her baby. If you had put epidural, with the old epidural, which is really local anesthetic, you don't get off the table because it can paralyze you. It'll block everything. And if the local anesthetic gets into the fetal circulation, you got a problem. There's nothing you can do. You can wait. What happens if the morphine gets into the fetal circulation and you're worried about respirate? What do? How do you treat it? Quickly, immediately. Naloxone, Narcan, and immediately you're back to square one. So morphine is a great drug. You got to know how to use it. What other politically sensitive approach to pain control should be considered? Yep. Okay? Absolutely, cannabis. It's just been approved in Canada for neuropathic pain. I don't know that it'll ever be approved in this country for the political reasons. Does it work? In animals, it works spectacularly. It makes sense. We understand how it works. To be honest, the studies in humans are not satisfactory in my mind. There are some that shows it work. My personal belief is that it will work. I'd like to see bigger studies. I think it makes sense. Does it have side effects? Of course it has side effects, right? Should it be approved? I think very soon it should. Will it be approved in this country for pain? I doubt it. I doubt it. Finally, psychology. Placebos. How many people think if you respond to a placebo that you probably don't have pain? Good. The fact is, the more pain you have, the more likely you're going to respond to a placebo. Pain is a perception. Why shouldn't it be sensitive to psychological controls? It works. And here's a kicker, beautiful. Placebo analgesia, placebo pain control, there's good evidence. It can be reversed by naloxone. The data is very good. All right? A guy named Benedetti, I can put you onto some other studies. What that says is it taps into the endorphins, releases endorphins, and off you go. Okay? Acupuncture. In my mind, does acupuncture work? For some people, for sure. How does it work? My reading of the literature, my interpretation, is that it's a placebo. Now remember, that doesn't mean it doesn't work. I just think it's an exotic placebo that uses psychological power, belief, in the system that can actually block pain. I don't, and why do I say this? For two major reasons. It turns out it doesn't make a difference where you put the needles. If it works, it'll work whether the needle's here or here. And more importantly, it doesn't work in children for pain. Under 10 years of age, it's never used. Why not? Well, children are not placebo reactors. When the big needle comes along in the white coat, that's bad news. That's not good news. All right? There's no placebo in a kid. All right? Yeah, I don't want to go to the dentist. There's nothing good about that. Children are not placebo reactors. It takes time. There's a cognitive set to be able to be influenced by that. Remember, medical students say it's the patron saint of acupuncture, but I don't know about that. Anyway, stress and anxiety, the setting. I talked about soldiers who in battlefields don't have pain, football players. This is an interesting picture. Ronald Reagan was shot 20 seconds before this picture was taken. Didn't know he was shot. Nobody knew. Brady was on the ground shot. Everyone's worried about that. Was that an injury stimulus? You bet it was. All right? So the stimulus itself does not determine the pain. There's so much more going on, and the clinician and the friends of the individual need to take that into account. Finally, hypnosis. I happen to think hypnosis is one of the most profound ways to treat pain. I think it's underutilized. If pain is a cognitive thing, a perception, then manipulating cognitive sets should work, and I think it can. And it's very different, by the way. Hypnotic analgesia, which works, is not reversed by naloxone. Clearly doesn't involve the endorphins. As a little aside, how many people think when you go jogging and you feel good, it's endorphins? Few people. There's no evidence for that. All right? How would we test it? Naloxone. I'm waiting to do that experiment to the people in my lab who leave the lab at 3 o'clock in the afternoon and go for a run and say, I got a jogger's high. Give them naloxone. If they never run again, then it's endorphins. Anyway. Here is that area I showed you. Here's the pain, the anterior cingulate gyrus. This is the unpleasantness correlate. Very high. This is the sensory discriminative. Now you hypnotize the subjects. Beautiful study published in Science so that it's no longer unpleasant. What happens? That activity pretty much disappears, but the activity in the sensory part of the brain doesn't, stays the same. In other words, the information got to the brain, but the perception was altered. What a wonderful way to treat pain. How does it work? I don't know, but it illustrates so strongly that pain is much more than a stimulus, and you've got to use everything you can to regulate it. So by summarizing, I'll just leave you with this. Here's the pathway. It's more complex. I didn't go into all the details. The information gets to the brain. That we know about. It's not just a pain pathway. It's a modifiable pathway that changes in the setting of injury. You can treat by targeting changes in the nerve in the skin. You can pour drugs at the cord, and morphine's just one of them. But don't forget that pain's a perception, and you can manipulate the brain. All right? And I'll end by reading you some. I got into this, the students. It started as a joke. I wrote all these stupid poems. For my lectures, I'll read you one. The bane of pain is plainly in the brain. Now, pain is an intricate potion of sensations, cognitions, emotions. Acute pain may be terrible, and when chronic, unbearable, not something that you treat with mere lotions. But although pain may not be easy to bear, there's a reason for pain being there. It's critical to know, lest a cancer unbeknownst grow. Pain signals a need for repair. You learned of children with congenital insensitivity to pain. They're unaware if they have fractures or sprains. These children are rare, but they need constant care, or their injuries will not be contained. The small fibers you learned are essential to establish a painful potential, but shake your hand or vibrate, and you may close the gate so that the pain is no longer sequential. Was this known to that student of pain? The Marquis de Sade was his name. His charisma, it gripped you as he smilingly whipped you, and the pain could just drive you insane. The good news is that there are myriad ways to control pain, which is perhaps why cutting the cords on the wane. Find out what the morphine dose is, even consider hypnosis. Remember, pain's a complex product of the brain. In this regard, find a pregnant woman and ask her, is Lamaze merely a ploy to distract her? Or when labor pain is not perceived by the brain, are endorphins a relevant factor? Now, of course, endorphins, there are numerous classes. Some, reportedly, are as potent as grasses. So if you're in pain, just depend on your brain, because your endorphins are the true opiates of the masses. Thank you very much. Okay, thank you for listening. I'll take questions. We have lots of time. Yes, sir. Oh, there's a very would a panel of pain specialists vote to bring Vioxx back? The answer is, I would think many of them would, with a huge black box warning saying, be careful. Look, we know that aspirin has a terrible side effect profile. It's just been approved. I think people think it is a very good drug. A lot of patients like it, and the beauty of it, one pill a day. Which, when somebody is a 60, 65, 70-year-old, they have lots of problems, they got diabetes, they got this and that, and they got a bucket full of pills. Instead of having to take 4 ibuprofen every 4 hours, or 2 or whatever, they can take 1 pill in the morning. That's a huge advantage. It's idiosyncratic, patients like it, but of course you've got to put this very big caveat around it, and so as long as they're not going to potentially be sued, they might be willing, but as long as they might be sued, then they'll say no. But I think it's a good drug. Yes, sir. You're absolutely right. The point is that you said that we can be regulated by dose, and you're absolutely right, provided you can get enough of the dose to produce the effect, right? Because if you need to lower the dose in order to reduce the side effects, you may not get the effect. Remember I said the whole game here is big effect, little side effect. We call therapeutic window. If you can't get it big enough, you have a problem. Every drug will have side effects. It's inevitable. The best drugs will have fewer side effects, but everything in too high a dose will guarantee to have side effects. Yes, ma'am? There's very few side effects of deep brain stimulation. In the worst case, the worst that can happen, and there maybe are a couple of 5,000 patients where the electrode, and the odds are very small, hit a significant vessel, all right? And you could have a bleed, and you could die. So in the worst case, but you can die, there's a percentage of chance you'll die in any surgery from general anesthesia. Putting the electrode down doesn't do anything. Is it possible to have infection near the opening? Always. But that's the case with any surgical procedure. So you'd use the standard approaches. What we call the morbidity, in other words, the bad consequence is really very low with this procedure. It's not just used for pain, by the way. Patients with Parkinson's that are stopped responding to say, DOPA will have lesions or stimulation of a different part of the brain to control tremor. It's the same procedure. And so electrical stimulators in the brain are not new, and the actual procedure is not a problem. Technically, it's not a big deal. Yes, sir. Okay, so the question is, this Newsweek article emphasized this notion of neuroplasticity and the idea that, in fact, the notion that the implication really is when someone has an injury, you want to get in there really quickly and block the pain immediately. And they're doing that now. They're talking about doing blocks right on the battlefield. Because remember, one of the big problems with Iraq, there are many, but the major problem is that the armor, to some extent, is actually a lot better than what we're reading. And what happens is people get injured, and while in Vietnam they died, now they end up with long-term injuries and long-term pain. Get in there and treat literally on the battlefield. The question was, so that's the idea that there's plasticity, there's changes, and I talked about memories, and that these are maladaptive. They can be maladaptive. But all of these other psychological manipulations, are they modifying the plasticity? I don't think so. I think what they're doing, the plasticity has occurred, the information is getting to the brain, and what you're trying to do is alter the cortical representation. You're actually dealing with the pain side of the problem rather than the processing side. And there's a big difference. And I think that many alternative approaches are effective, because they're all operating at that level, all right? Like acupuncture, biofeedback, and a variety of other things. I don't mean to be demeaning. Placebos work. Look, here's an example. Sir, you're my patient, all right? Now, just to prove to you about placebo, I think you'll believe it. Now, you come in, you have a pain problem. I've been treating you for 6 months. And so, look, we're having trouble. And I said, look, sir, I want you to try this new pill. I just spoke to, well, to be really honest, I don't think it's going to work. You know, I've given it to 10 of my patients and nothing. But look, I got nothing for you. But, you know, you never know. You could get lucky. The guy from the big pharma, he told me it's great. So here, give it a try. All right, that's scenario number 1. Same pill. Same pill. I come in. Sir, look, I'm really excited about this. This is a new drug. I've tried it in several patients, and things look really good. We're getting good results. The data from other studies is really, I mean, I'm really optimistic. I think it's worth trying. Try it. Take it a few times. It may not work right away, but I'm really optimistic. Okay. What's the better approach? I mean, duh. Same pill. If it's all about pharmacology, binding, it shouldn't make a difference. The second one I added a placebo. Every drug, if the physician administers it right, has a placebo component to it. You have to believe it's going to work. The other thing is actually called the nocebo. Literally, I can make a drug that is known to work worse by giving you lousy information, bad information. The brain really influences. I don't know if Marika, who teaches pharmacology, wants to throw a dart at me, but I really believe that absolutely. Okay? Yes, ma'am. Okay, without question, people with chronic pain will have depression. Be very unlikely not to. Okay, so if you were to treat them with psychoactive drugs, antidepressants, at antidepressant doses, it's a good idea if they're depressed. All right? You have to face the day. You got a pain problem. Deal with the depression. It's a good idea. I don't believe that if you're depressed, you're more likely to become a chronic pain patient. I don't know if there's that good evidence. Now, one other important thing. For neuropathic pain, not for the tissue injury pain, neuropathic pain, there is very good controlled trial evidence that some of the antidepressants, independent of their effect on depression, in fact, at doses that are not even antidepressant, can be effective for neuropathic pain. Postherpetic neuralgia and diabetic neuropathy. And the drugs I'm talking about are the old antidepressants, the sort of what we call dirty ones, the so-called tricyclics like Elavil, all right? If you can tolerate the side effects, it can be very effective in some patients. Or the very newer ones like Cymbalta, duloxetine, venlafaxine. These are mixed, what we call serotonin norepinephrine. It turns out, interestingly, the pure serotonin uptake inhibitors, the SSRIs, like Prozac, don't work. They work for depression. They don't do anything for neuropathic pain. We can talk in some other time about mechanisms. But so the antidepressants at doses that are not even antidepressants, if you use the right ones, can be remarkably effective in some patients. You can't predict ahead of time for neuropathic pain. But unfortunately, there are plenty of people who still have trouble. Local anesthetic patches can be effective for patients with postherpetic neuralgia. You block the input right at the level here. Ideally, we're going to eventually come up with a local anesthetic that you can pop a pill that mimics what those kids in Pakistan have, because we now know the exact mutation that causes that, and what turns out to be exciting. So local anesthetics work on sodium channels. They affect ion flow. They affect conduction of impulses. The typical local anesthetic is what? Like lidocaine, Novocaine, that the dentist uses. Well, that works beautifully. That's why the dentist can work on your mouth. But if you get it systemically, you can have cardiotoxicity, brain toxicity, because that's a non-selective blocker of the conduction. The kids have that defect in a subtype of channel that is only found in the, quote, pain fiber. If you can develop a good drug, you may be able to massively open up the therapeutic window, selectively block pain. Quite exciting, based exactly on looking at the genetics of pain, transferring it into the clinic, developing a new drug. It's very exciting. I'm really optimistic. Yes. The question was, I did go through the hypnosis quickly. I was worried about time. I'll tell you one other hypnosis story that will help. Hypnosis is not a placebo, and I say that because it's not reversed by naloxone. All right? It's very different. And placebos, we think, block the information flow to the brain. In the case of hypnosis, I think the information gets to the brain and it's altered. How do I know that? Let me tell you from partly that study, but an older study by Hilgard at Stanford. Bizarre study, let me tell you about it. He was a psychologist, wrote the classic textbook of psychology, hypnotist who studied pain. Here's the experiment. Subject is sitting there, they have a blood pressure cuff on. You don't completely paralyze the arm, and you get him to exercise or put it into ice water. Let me tell you, that's excruciatingly painful. All right, ischemic pain is real bad. So now this patient, this individual subject saying, yeah, does that hurt? Oh, yeah, it's really, of course it hurts. Terrible. Okay, then you hypnotize them. You hypnotize them in the same way so that it's not unpleasant. And 80% of people are hypnotizable. So you could change it so they don't even feel the unpleasantness of that situation. Oh, that's right. You hypnotize them and you ask them, how do you feel? And they say, I'm fine. It's fine. So it's working. The hypnotic analgesia worked. Everything's great. No, it's not unpleasant. You sure it feels? Oh, no, it feels like warm, tepid water. Great. Now you tap into the subconscious and you use the hidden observer and you say, tell me what you're really feeling. And you use automatic writing to report, and the hand starts writing, it hurts like hell, stop it, it's burning, it's just as bad as it was. I feel absolutely fine. Oh, I'm fine. It's terrible, terrible. You know, you just like split the brain, but it's bizarre, it's Twilight Zone type stuff, but what it tells me, I don't know how it works, but clearly the information got to the brain because the verbal report, I mean the hand report, said it still hurts. The verbal report said, I really completely screwed this up, I'm tired. I think you get the point. The information gets to the brain, the perception is altered, the ultimate effect is that you can reduce pain by affecting the emotional component. By hypnosis, it's not placebo, it's not touched by naloxone. And by the way, placebo responders, they always say, here, look to your left, now look to your right. One of you three is a placebo responder. I don't know which one. It's about 35%. Hypnosis, about 80% of people are hypnotizable. I'm not. I tried. Didn't work. In the back. I talked about TENS units. TENS units, transcutaneous electrical nerve stimulation, they work for superficial pains. They don't work when the pain's deep. They're idiosyncratic. You can't predict. They can be effective for certain people. They're expensive. And so that's one of the reasons that most physicians aren't going to prescribe it. And most pains are deep. Cancer pains are deep. They're not effective. They're effective for incision pain. For burns, they can be very effective. They don't work for backache. They'll be very ineffective. So, you know, you just can't sort of vibrate enough and get deep and get those large fibers. It just doesn't work. So I think it's a matter of, it just doesn't have a broad enough spectrum. And they're not cheap. They're not cheap. Go to Brookstones and buy a vibrator. If it works, it'll work. Yep. Why do some people report that they like the sensation of pain? Somebody, yeah, I know. Well, all right. I don't know the answer to that, obviously. I don't think, some medical students, they always ask that question. You know the story of the masochist who said to the sadist, hit me. And the sadist said, no. And the masochist said, thank you. Anyway, the point is, I don't think that that's pain. I don't think it's pain in the same way. It is, you know, it could be more like a sexual type thing. I don't consider it pain. I don't know how to put it into context. The fact that the word is used, they like painful stimuli, but I think it's not generating the same kind of thing. It's a learned thing, clearly. It emphasizes that the stimulus doesn't determine what the perception will be, and in this individual, for whatever reason, it turns them on rather than making it unpleasant. I don't know how it comes about. Oh boy, all right, fibromyalgia. Big problem, but very much in the news, getting a lot of attention these days. So fibromyalgia used to be called fibrositis. An itis, as you know, means inflammation. These are people, mostly women, about 2/3, between 30 and 50, quite common, where it's focused. And they have trigger points. They have sensitive sites where it's very painful to just touch them. They're very predictable where the sites are in the neck and different parts. The itis was called, but then they went and looked, and there's no signs of any inflammation. There was clearly not. So they dropped the term, they call it fibromyalgia, sort of an algia meaning pain. So it's this diffuse, non-specific pain with trigger points. Nothing works to treat. It's horrible. It's debilitating. The only thing that is really, that, if you will, read the pain literature, that actually works at all is antidepressants, all right, at doses that are antidepressant, and exercise, physical therapy. It's the only thing that has been shown to effectively work. Now, I'll be honest, half the community thinks that these patients have psychiatric problems. The other half doesn't. And this pendulum is starting to swing towards the notion that it is a brain disorder. There's imaging studies that are showing this, that in fact these individuals are processing stimuli inappropriately, that they don't transmit information to the brain, that the brain imaging studies are quite different. There's some studies suggesting that there's dopaminergic changes. Some people think it's a neuropathic type pain condition. All I can say is that it is a hot topic. It's a critical one. There's lots of patients. But the pendulum is swinging, and there's more money being put into trying to study what's going on rather than the knee-jerk assumption, which was the case, that, oh, these are people who are just totally screwed up, and I don't want to see them. They're very difficult people to work with because nothing works. Things don't work. But that doesn't mean that, therefore, their pain is some imaginary thing. For any individual, something might work, but there's nothing as a general rule that you can say would be effective.